Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
This session will guide us through the critical considerations and strategies required when patients on various antithrombotic medications experience bleeding or need urgent procedures. It is important to think of this material as essential knowledge for navigating complex coagulopathic states in critically ill patients. We will explore specific approaches for managing bleeding associated with vitamin K antagonists, such as warfarin. Understanding their mechanism of action is vital, as well as the role of specific reversal agents like vitamin K and prothrombin complex concentrates. Next, we will address direct factor Xa inhibitors, including apixaban and rivaroxaban. In this section, we will examine the use of specific antidotes such as andexanet alpha, along with nonspecific agents like prothrombin complex concentrates. The focus will then shift to direct thrombin inhibitors, particularly dabigatran. We will discuss the specific antidote idarucizumab and alternative management strategies available in such cases. We will also consider unfractionated heparin. It is important to highlight its mechanism of action and the specific reversal agent known as protamine sulfate. In relation to low molecular weight heparin, such as enoxaparin, we will explore the partial reversal that can be achieved with protamine sulfate. Additionally, we will cover antiplatelet agents like aspirin and clopidogrel. This area presents a challenging landscape regarding platelet transfusion and other potential management strategies. Lastly, we will discuss fibrinolytic agents, including alteplase. Here, we will outline management strategies that focus on fibrinogen replacement when specific antidotes are unavailable. Throughout this exploration, we will emphasize the importance of a global assessment of the patient's coagulation status. We will also discuss the limitations of traditional laboratory tests and the potential utility of viscoelastic assays like thromboelastography and rotational thromboelastometry in certain populations. The crucial role of clinical context in guiding management decisions will also be highlighted. Finally, we will touch upon the complex decision of when and how to safely restart antithrombotic therapy following a bleeding event. This lecture outlines 10 learning objectives aimed at enhancing your understanding of the reversal of anticoagulants and antiplatelet agents in urgent clinical situations. Overall, these objectives provide a comprehensive framework for understanding the crucial aspects required for effective management in the context of anticoagulant and antiplatelet reversal. The first objective is to identify the key considerations when assessing a patient's coagulation status. It is essential to recognize that critically ill patients may present with multiple coagulopathies, complicating the assessment process. Next, we will describe the utility and limitations of traditional coagulation tests, such as the International Normalized Ratio and Activated Partial Thromboplastin Time, as well as viscoelastic assays like thromboelastography and rotational thromboelastometry. These tests are particularly relevant in evaluating coagulopathy among specific populations, including individuals taking direct oral anticoagulants and those with liver disease. The third learning objective focuses on outlining the immediate management steps for patients experiencing major bleeding while on oral anticoagulants. Prompt intervention is crucial in these scenarios to mitigate the risks associated with significant hemorrhage. Following this, we will compare and contrast the main reversal agents for vitamin K antagonists. This will involve explaining their mechanisms of action, indications for use, dosing considerations, and preferred application. The agents include vitamin K, 4-factor prothrombin complex concentrate, fresh frozen plasma, and recombinant activated factor 7. The fifth objective evaluates specific reversal strategies for direct factor 10 inhibitors. A discussion of the role of andexanet alpha for the reversal of apixaban and rivaroxaban will be included, as well as the evidence supporting the use of 4-factor prothrombin complex concentrate as an alternative for other direct factor 10 inhibitors. We will explain the specific reversal strategy for dabigatran, emphasizing the use of idarucizumab. Furthermore, we will list alternative and less specific options available when the specific antidote is not accessible. The seventh learning objective details the primary reversal agent for unfractionated heparin. This includes a focus on its mechanism of action, dosing, and administration while recognizing its variable effectiveness for low molecular weight heparin and identifying alternatives for low molecular weight heparin when protamine is either insufficient or contraindicated. In addition, we will assess the evidence and recommendations regarding the use of platelet transfusion and desmopressin for reversing antiplatelet agents. This is particularly important in the context of intracranial hemorrhage, and we will identify the situations in which these strategies might be employed. The ninth objective addresses the primary management strategies for bleeding associated with fibrinolytic agents. Given the absence of specific antidotes, the focus will be on fibrinogen replacement as a means of managing such bleeding events. Finally, we will analyze the factors that influence the complex decision of whether and when to safely restart anticoagulation therapy following a bleeding event. This will involve assessing the risks of thromboembolism and rebleeding, considering the characteristics of the specific bleed, especially intracranial hemorrhage, alongside various patient factors. When approaching anticoagulant reversal and managing bleeding, it is essential to consider several general principles derived from existing literature and empirical evidence. These principles serve as a foundational framework for addressing the complexities inherent in these clinical scenarios. By understanding and applying this framework, healthcare professionals can effectively navigate the intricacies of anticoagulant management, ultimately optimizing patient outcomes. One of the most important factors to consider is understanding the overall extent of coagulopathy in the patient. This involves more than simply checking a single laboratory value or identifying the specific anticoagulant the patient is using. Critically ill patients, in particular, frequently exhibit multiple coagulopathies at the same time. As a result, it is essential to conduct a thorough assessment that takes into account all medications the patient is taking. Additionally, all available coagulation laboratory results must be reviewed carefully. This comprehensive approach ensures that the patient's coagulation status is fully understood and appropriately managed. In addition to evaluating the present coagulopathic state, it is crucial to consider the broader clinical context, which encompasses all existing coagulopathies and the full range of anticoagulant medications that the patient is currently taking. This comprehensive approach is essential for preventing management errors. When addressing bleeding in patients who are on oral anticoagulants, which include both direct oral anticoagulants and vitamin K antagonists, it is important to assess the severity of the bleeding. This assessment is vital for making informed treatment decisions that aim to achieve hemostasis and maintain organ function. The initial evaluation should include a thorough history and physical examination, monitoring of vital signs and laboratory tests to establish the timing, location, and severity of the bleeding, in addition to determining whether it is ongoing. It is also critical to promptly and frequently assess for signs of hemodynamic instability. For patients who are experiencing major bleeding, a series of interventions should be implemented simultaneously. The first step is to discontinue the use of anticoagulants and antiplatelet agents. Additionally, it is important to ensure a secure airway and establish large-bore intravenous access. For most patients who have significant bleeding, reversing the oral anticoagulant is recommended if an appropriate agent is available. However, it is essential that the initiation of reversal does not delay resuscitation efforts or local hemostatic procedures. In cases of ongoing bleeding or hemodynamic instability, local measures to control the bleeding, such as applying pressure or packing, should be employed alongside volume resuscitation using intravenous isotonic crystalloids to restore hemodynamic stability. It is also necessary to address any hypothermia and acidosis, as these conditions can exacerbate coagulopathy. Early consultation with relevant specialists, including surgery, interventional radiology, or gastroenterology, is important for the definitive management of the site of bleeding, particularly in critical locations. Clinicians must also be aware of any comorbid conditions and concurrent treatments that could contribute to bleeding or affect management decisions. Conditions such as antiplatelet therapy, thrombocytopenia, uremia, and liver disease should be treated appropriately. For instance, patients with renal dysfunction may have increased levels of direct oral anticoagulants and prolonged half-lives, which may make them suitable candidates for treatments such as desmopressin acetate or cryoprecipitate to address uremia-related platelet dysfunction, in addition to optimizing renal function. Liver dysfunction can also have implications for bleeding by impairing the metabolism of anticoagulants. In such instances, traditional coagulation tests, including prothrombin time, international normalized ratio, and activated partial thromboplastin time, may not provide reliable results. Therefore, viscoelastic testing such as thromboelastography or rotational thromboelastometry and consultations with hematology can be particularly valuable. Furthermore, the use of antifibrinolytic agents such as tranexamic acid or epsilon aminocaproic acid may also be considered. Regarding platelet transfusions, the routine use of transfusions for bleeding patients who are receiving antiplatelet agents is generally not supported by evidence. Studies, including the patch trial, have shown no benefits and potential for adverse outcomes. However, platelet transfusions may be considered in specific situations, especially if other reversal measures have failed. In the case of non-major bleeding events, routine reversal of oral anticoagulants is generally not advised. Nevertheless, it is often prudent to temporarily discontinue oral anticoagulant therapy until hemostasis is achieved. Finally, it is important to carefully consider the risks and potential complications associated with aggressive fluid resuscitation, as these can exacerbate bleeding and impact patient outcomes. It is important to recognize that traditional coagulation parameters do not always provide an accurate reflection of a patient's true coagulation state. This issue is particularly evident in certain populations, such as individuals with cirrhosis or those suffering from disseminated intravascular coagulation. In these cases, thromboelastography can be a valuable tool, offering a more precise assessment of the patient's coagulation status. TG, along with rotational thromboelastometry, belongs to a class of tests known as viscoelastic hemostatic assays. Unlike traditional coagulation tests, which include the prothrombin time, international normalized ratio, and activated partial thromboplastin time, which reflect an in vitro coagulation pathway, TG provides a broader picture of coagulation. TG and rotational thromboelastometry enable the measurement of both cellular and plasma components involved in clot formation and fibrinolysis. This includes assessing the entire process of clot development, strength, and breakdown. In contrast, traditional tests primarily measure the time it takes for clot initiation within a specific pathway. In critically ill patients who often experience multiple coagulopathies, traditional coagulation parameters, such as the international normalized ratio, do not always accurately reflect the true coagulation state. In these scenarios, TG may provide a more precise assessment. TG proves particularly beneficial in cases of cirrhosis, where it significantly outperforms traditional coagulation tests such as the international normalized ratio. TG also demonstrates a documented ability to guide hemostatic replacement in the operating room, especially during complex surgeries like liver transplantation. In situations where there is uncertainty regarding the necessity for factor replacement, ordering thromboelastography may provide additional insight. Some clinical guidelines suggest incorporating TG whenever repeating coagulation studies, such as complete blood counts and specific coagulation tests, for follow-up care. Viscoelastic testing, including TG and rotational thromboelastometry, may offer value in assessing hemostatic function in patients suffering from liver disease. Additionally, viscoelastic assays demonstrate dose-dependent changes when responding to direct oral anticoagulants. This includes medications such as apixaban, batrixaban, edoxaban, and rivaroxaban. Preclinical studies involving animal models and ex vivo observations have also noted dose-dependent effects concerning dabigatran and rivaroxaban. However, the existing literature emphasizes that the thresholds for TG and rotational thromboelastometry that are sensitive and specific enough to guide the use of reversal agents for direct oral anticoagulants have yet to be established. While these assays are capable of detecting coagulation abnormalities that may not be evident in traditional tests for patients with intracranial hemorrhage, it remains unclear whether the findings from these tests correlate with patient outcomes. When factor concentrates, such as prothrombin complex concentrates, are administered for newer oral anticoagulants, their use may lead to reductions in laboratory parameters, including TG results, even when patient outcomes are not favorable. This suggests a disconnect between laboratory corrections and clinical benefits in these particular contexts. Understanding the significance of viscoelastic studies, such as TG and rotational thromboelastometry, in patients suffering from intracranial hemorrhage is highlighted as an area of emerging and active research. Further studies are necessary to determine whether the results from these tests correlate with patient outcomes. The role of blood tests, including TG and point-of-care assessments, in targeting the reversal of anticoagulation therapy also warrants investigation. While TG with platelet mapping has been proposed for assessing platelet inhibition in cases of traumatic intracranial hemorrhage, existing literature notes that these assays are not routinely utilized. In essence, TEG offers a comprehensive view of coagulation that surpasses what traditional tests provide. It proves to be especially useful in complex situations such as critical illness and cirrhosis and aids in guiding surgical hemostasis. Although it shows dose-dependent effects in response to direct oral anticoagulants and can identify coagulation abnormalities that traditional tests may overlook in cases of intracranial hemorrhage, its utility for specifically guiding the reversal of direct oral anticoagulants and its correlation with clinical outcomes in these scenarios remain inadequately established and are subjects of ongoing research. Let us explore the insights literature and evidence provide regarding the management of bleeding in patients who are taking vitamin K antagonists, particularly focusing on warfarin, while situating this discussion within the broader context of anticoagulant reversal and bleeding management. This examination serves to illuminate the complexities related to reversing the traditional class of oral anticoagulants. Warfarin, classified as a vitamin K antagonist, has stood as a fundamental aspect of oral anticoagulation for more than 50 years. Its primary mechanism of action involves the inhibition of vitamin K-dependent clotting factors, which include factors 2, 7, 9, and 10. It also affects the natural anticoagulant proteins C and S. Therapeutic doses of warfarin lead to a reduction of active factors by 30 to 50%. Warfarin is indicated for a range of medical conditions, including the prophylaxis and treatment of venous thromboembolism, the management of atrial fibrillation, and complications associated with mechanical heart valves. One of the serious risks associated with warfarin therapy is intracranial hemorrhage. This occurs with a frequency 7 to 10 times higher than in individuals who are not receiving anticoagulation treatment. Intracranial hemorrhage related to vitamin K antagonists typically results in larger hematoma volumes and an increased likelihood of hematoma expansion, which can elevate both mortality and morbidity rates. Additionally, the long half-life of warfarin, which can range from 20 to 60 hours, extends the risk of prolonged bleeding. Traditional coagulation tests, such as the international normalized ratio, are regularly employed to monitor the effects of warfarin. However, it should be noted that in critically ill patients, particularly those suffering from conditions such as cirrhosis or disseminated intravascular coagulation, these traditional parameters may fail to adequately reflect the overall coagulation status of the patient. When addressing bleeding or the necessity for urgent procedures in a patient taking warfarin, it is essential to act swiftly. The initial step in managing such situations is to discontinue warfarin promptly, especially when bleeding, particularly intracranial hemorrhage, is either present or suspected. For cases associated with vitamin K antagonist-related intracranial hemorrhage, urgent reversal of anticoagulation is highly recommended. The treatment should ideally commence based on the type and timing of the last dose, rather than deferring it until laboratory results are available, particularly in instances where significant levels of anticoagulants are suspected. Initiating reversal earlier has been associated with improved patient outcomes. The primary strategies for reversing the effects of warfarin focus on replenishing the depleted vitamin K-dependent factors and providing the necessary substrate for their synthesis. Vitamin K, also known as phytonadione, serves as a specific reversal agent for vitamin K antagonists. Its role is crucial as it provides the liver with the necessary substrate to synthesize functional clotting factors, specifically factors 2, 7, 9, and 10. Vitamin K is essential for achieving a durable reversal of warfarin's effects and preventing a subsequent rebound increase in the international normalized ratio, INR, as administered factors diminish in their activity. This agent should be administered as soon as possible and is ideally given concurrently with other reversal agents for optimal effectiveness. In cases requiring emergent reversal of warfarin, the recommended dose is 10 milligrams intravenously. This dose is typically infused over a period of 15 to 30 minutes. Administering vitamin K slowly through an intravenous route provides a more predictable and rapid reduction in INR, which usually occurs within 4 to 6 hours, compared to oral administration that takes 18 to 24 hours and subcutaneous administration, which is deemed unpredictable and not recommended in urgent situations. Additionally, concerns regarding anaphylaxis with older intravenous preparations are generally not observed with the current versions. It is important to emphasize that administration of vitamin K does not result in immediate correction of coagulation parameters. In non-emergent scenarios involving supratherapeutic INR levels without bleeding, the management approach entails holding warfarin. This may include low-dose oral or intravenous vitamin K, with doses of 1 to 2.5 milligrams given orally or intravenously for an INR range of 5 to 9, and doses of 2.5 to 5 milligrams for an INR exceeding 9. It is noteworthy that low-dose intravenous vitamin K might present a higher risk of overcorrection compared to oral vitamin K. In these instances, generally, factor replacement is not indicated for patients who are not experiencing bleeding. Attempting to normalize a high INR to below 1.7 with fresh frozen plasma for minor procedures, such as the insertion of a central line, is recognized as both impossible and dangerous. Plasma coagulation complexes, known as PCCs, are concentrated products that contain vitamin K-dependent factors. One specific type, the 4-factor PCC, which is FDA approved, is used for urgent reversal of vitamin K antagonists. In the United States, Kcentra is a specific 4-factor PCC available for this purpose. This product consists of factors 2, 7, 9, and 10, along with natural anticoagulants such as protein C and S. PCCs are preferred agents for rapid reversal in cases of major bleeding or during urgent medical procedures over fresh frozen plasma. Their advantages include a lower volume required for administration, faster delivery, and a more consistent and rapid reversal of the international normalized ratio, INR, compared to fresh frozen plasma. This efficiency in reversal helps to reduce risks such as volume overload and transfusion-related acute lung injury associated with large plasma volumes. Numerous studies, including randomized trials, support the effectiveness of 4-factor PCC in rapidly reversing INR and in reducing the growth of hematomas associated with vitamin K antagonist-related intracranial hemorrhage when compared to fresh frozen plasma. Additionally, one analysis found that PCC is more cost-effective than fresh frozen plasma for emergency reversal of warfarin. Currently, most hospitals in the United States use PCC for managing warfarin-associated hemorrhages. When dosing PCC for warfarin reversal, the treatment is typically weight-based and adjusted according to the INR. Suggested doses range from 25 to 50 international units per kilogram, depending on the INR level and the patient's weight. There are specific dose recommendations for different INR thresholds, such as when the INR is 1.7 or 2.0 or higher. While fixed-dose strategies are sometimes employed, variable dosing remains the standard, primarily based on historical practice rather than comparative trials. PCC should always be administered alongside intravenous vitamin K to ensure sustained reversal and to prevent the return of coagulopathy, as the infused factors are metabolized and cleared from the body. However, using PCC carries a risk of thrombosis, which may be linked to an accumulation of factor II when large or frequent doses are given. Formulations that contain endogenous anticoagulants, like 4-factor PCC or Kcentra, are believed to present a lower risk of thrombosis in comparison to older products or 3-factor PCCs. When considering the use of PCC, one must carefully balance the potential thrombotic risk against the critical need for rapid hemostasis. Factor IX complex, a type of 3-factor PCC, such as Profil-9SD, is an alternative to 4-factor PCC for patients who have a history of heparin-induced thrombocytopenia. However, it does not contain the endogenous anticoagulants found in 4-factor PCC and is therefore considered riskier and less supported by available evidence. Fresh frozen plasma, FFP, contains coagulation factors and has historically been used for reversing vitamin K antagonists, VKAs. However, it is less effective for rapid international normalized ratio, INR, reversal compared to prothrombin complex concentrates, PCCs. FFP requires larger volumes, typically ranging from 10 to 15 milliliters per kilogram. This significantly increases the risk of volume overload, especially in vulnerable patients such as those with heart failure, atrial fibrillation, valvular disorders, or liver disease. Older retrospective studies indicated no difference in patient outcomes between FFP and PCC, despite the slower INR reversal seen with FFP. On the other hand, randomized trials demonstrated that PCC results in less volume overload. If prothrombin complex concentrates are unavailable or contraindicated, it is recommended to use FFP combined with vitamin K as an alternative treatment instead of providing no treatment at all. Although there are recommendations against the routine use of plasma for oral anticoagulant reversal, including VKs, due to a lack of evidence and associated risks, plasma continues to be utilized in real-world practice. This is often because of clinician familiarity and comfort with the treatment, despite the literature and evidence consistently advising against the use of plasma for oral anticoagulant reversal. Recombinant activated factor VIIa can reduce INR levels, but the literature and evidence strongly recommend against its use for VKA reversal in cases of intracranial hemorrhage. This is due to very limited evidence showing improved hemostasis, mortality, or functional outcomes compared to available alternatives. Furthermore, combining recombinant activated factor VIIa with prothrombin complex concentrates or fresh frozen plasma may heighten the risk of thrombosis or disseminated intravascular coagulation, DC. Additionally, recombinant activated factor VIIa is significantly more expensive than other reversal strategies. It may only be considered under specific circumstances where blood products are refused, such as in patients who are Jehovah's Witnesses, although data on its efficacy in that context are limited. Reversal of anticoagulation is typically monitored using the International Normalized Ratio, often referred to as INR. In cases of intracerebral hemorrhage, it is recommended to repeat INR checks every 3 to 6 hours to ensure adequate reversal with a target INR of less than 1.4 or 1.3. If the INR remains elevated 24 to 48 hours after the initial reversal, it may be suggested to administer repeat doses of vitamin K intravenously at a dosage of 10 milligrams or to provide factor replacement therapies such as prothrombin complex concentrate or fresh frozen plasma. In certain situations, such as in patients with liver disease, traditional coagulation tests may not be reliable. In these cases, viscoelastic testing, including thromboelastography and rotational thromboelastometry, can offer a more accurate assessment of coagulation status and guide need for factor replacement. Rapid reversal of warfarin in patients experiencing bleeding, particularly those with intracerebral hemorrhage, is strongly advocated. This approach typically employs a combination of intravenous vitamin K for durable reversal and 4-factor prothrombin complex concentrate for immediate replenishment of factors. 4-factor prothrombin complex concentrate is preferred over fresh frozen plasma due to its superior pharmacokinetic profile, lower volume, and reduced risks. Specific reversal agents for direct oral anticoagulants and recombinant activated factor 7A are generally not indicated or recommended for vitamin K antagonist reversal. Careful monitoring with the international normalized ratio and clinical assessment is essential to ensure effectiveness. Direct factor 10A inhibitors are a class of oral anticoagulants that includes agents such as apixaban, rivaroxaban, edoxaban, batrixaban, and fondaparinux. In the critical context of anticoagulant reversal and bleeding management, this class of drugs is essential to explore. It is important to understand the specific strategies tailored to these increasingly common anticoagulants. Direct factor 10A inhibitors have gained significant traction over the past decade. Unlike fondaparinux, which is a pentasaccharide that inhibits factor 10A indirectly via antithrombin, the primary mechanism of the other agents involves preventing the conversion of prothrombin to thrombin by inhibiting factor 10A. This action effectively inhibits the formation of fibrin clots. These agents are widely utilized for various medical indications. They are effective in preventing strokes in patients with non-valvular atrial fibrillation, treating and preventing venous thromboembolism, and providing prophylaxis after orthopedic surgery. One of the key advantages of direct factor 10A inhibitors compared to vitamin K antagonists such as warfarin is their association with a lower risk of intracranial hemorrhage. Understanding the pharmacokinetic properties of these medications is vital for proper management. They have variable half-lives, with rivaroxaban ranging from 5 to 11.7 hours, apixaban from 6.8 to 15.2 hours, edoxaban at 11.5 hours, and batrixaban from 19 to 27 hours. Fondaparinux has a half-life of 17 to 21 hours. Additionally, they exhibit differing degrees of renal excretion. Generally, these agents are highly protein-bound, making them ineffective for removal by hemodialysis, although edoxaban is somewhat dialyzable. Drug-drug interactions, often mediated by the enzymes CYP3A4 and P-glycoprotein, can also impact the levels and effects of these anticoagulants. Routine coagulation tests such as prothrombin time, international normalized ratio, and activated partial thromboplastin time are not reliably used to assess the anticoagulant effect of oral direct factor 10 inhibitors. They also do not accurately predict hemostasis or reversal efficacy. The sensitivity of these tests varies depending on the specific drug and assay. While these tests may show prolonged results, a normal reading does not rule out a clinically relevant anticoagulant effect. Specific assays for anti-10 activity, which are calibrated for each particular direct factor 10 inhibitor, can reliably measure plasma drug levels and the degree of anticoagulation. However, these assays are often not readily available in emergency settings in a timely manner for clinical decision-making. In some institutions, a generic chromogenic anti-10 assay is used. If the results of this assay are normal, it can help rule out clinically significant levels of direct factor 10 inhibitors. For patients with a known recent dose within the last 18 hours, assessing anti-factor 10 levels may not be necessary before administering specific reversal. Viscoelastic hemostatic assays, including rotational thromboelastometry and thromboelastography, may offer insights into the global coagulation status in the presence of direct factor X inhibitors. However, their use in emergency decision-making requires further exploration. Managing bleeding or the need for urgent procedures in patients taking direct factor Xa inhibitors requires prompt intervention. The first crucial step in controlling bleeding is to discontinue the direct factor Xa inhibitor. In cases of minor, non-life-threatening bleeds, temporarily halting the medication may be sufficient to achieve hemostasis. Andexanet alpha is a specific antidote for apixaban and rivaroxaban. This is an essential topic in the management of patients on these important anticoagulants, particularly in emergency situations that necessitate rapid reversal of their anticoagulant effects. For bleeding associated with certain direct factor Xa inhibitors, specifically apixaban and rivaroxaban, a dedicated reversal agent called andexanet alpha, also known as Andexa, has been developed and approved. Andexanet alpha is a recombinant modified inactive form of human factor Xa protein. Its mechanism of action allows it to function as a decoy by binding to and sequestering factor Xa inhibitor molecules with high affinity. This binding is specific to both direct and indirect factor Xa inhibitors. By binding to the inhibitor, andexanet alpha effectively reduces the concentration of unbound factor Xa inhibitor. This action subsequently restores the activity of native and endogenous factor Xa, thereby reinitiating thrombin generation and ultimately leading to clot formation. Andexanet alpha received approval from the United States Food and Drug Administration in 2018 under its Accelerated Approval Program. It was conditionally approved by the European Medicines Agency in 2019. Its approved indication is for the reversal of anticoagulation in patients treated with rivaroxaban or apixaban when reversal is necessary due to life-threatening or uncontrolled bleeding. It is important to note that evidence indicates it has not been shown to be effective for and is not indicated for bleeding related to any factor Xa inhibitors other than apixaban or rivaroxaban. However, it has demonstrated reversal activity in vitro and in studies involving healthy volunteers with other direct factor Xa inhibitors such as edoxaban and batrixaban. The dosing of andexanet alpha depends on the specific factor Xa inhibitor being used, the dose of the inhibitor, and the time since the patient's last dose. A common approach includes an initial intravenous bolus followed by a 2-hour continuous infusion. For example, a lower dose regimen, which consists of a 400 mg bolus followed by a 480 mg infusion over 120 minutes, may be utilized if the last dose of apixaban was 5 mg or less, or if the last dose of rivaroxaban was 10 mg or less, particularly if taken 8 or more hours prior or the timing is unknown for lower doses. A higher dose regimen, which involves an 800 mg bolus followed by a 960 mg infusion over 120 minutes, is prescribed for higher doses or if the last dose was taken less than 8 hours ago. The clinical evidence supporting andexanet alpha for reversing the effects of apixaban and rivaroxaban primarily comes from the Annexa 4 trial. This trial was a multi-center, prospective, open-label study conducted on patients who experienced acute major bleeding. The bleeding cases were predominantly intracranial hemorrhages and gastrointestinal bleeding, which occurred within 18 hours of the administration of factor Xa inhibitors. Key findings from the Annexa 4 trial revealed several important aspects regarding the efficacy of andexanet alpha. First, there was a rapid reduction in anti-factor Xa activity. In patients receiving apixaban or rivaroxaban, the median anti-factor Xa activity decreased by 92% within minutes after the andexanet bolus was administered. This reduction was both marked and swift. Furthermore, the study demonstrated excellent or good hemostatic efficacy based on predefined criteria. For example, a stable hematoma volume on imaging was observed for patients with intracranial hemorrhage. Overall, 82% of evaluable patients achieved this level of hemostatic efficacy 12 hours after the infusion concluded. Interestingly, in patients with intracranial hemorrhage, The magnitude of reduction in anti-factor 10A activity was identified as a predictor of hemostatic efficacy. The study also highlighted concerns regarding thrombotic events. Thrombotic events occurred in 10% of patients within 30 days in the full cohort. Earlier reports indicated that rates of thrombotic events range from 12 to 18%. Some evidence suggested that these rates were lower than those reported in certain studies of prothrombin complex concentrate for vitamin K antagonist reversal. There are legitimate concerns surrounding the potential for prothrombotic effects, possibly linked to andexanets binding to tissue factor pathway inhibitor. Transient increases in biomarkers such as D-dimer and prothrombin fragments 1 and 2 were noted during the study. Regarding mortality rates, all-cause mortality stood at 14% at 30 days in the full cohort. A notable limitation of the Annexa 4 study is its single-arm design, which indicates that it lacked a control group receiving standard care, which traditionally included nonspecific agents like prothrombin complex concentrates. This limitation makes it challenging to definitively attribute the clinical outcomes solely to andexanet alpha, as supportive care and the natural clearance of the drug also play significant roles in patient recovery. In the context of major bleeding associated with factor 10A inhibitors, particularly intracranial hemorrhage, guidelines and expert consensus statements recommend the use of 4-factor prothrombin complex concentrate or activated prothrombin complex concentrate if andexanet alpha is unavailable. 4-factor prothrombin complex concentrates contain factors 2, 7, 9, and 10, along with endogenous anticoagulants such as protein C and protein S. Activated prothrombin complex concentrate, like FIBA, contains activated factor 7 and inactive forms of factors 2, 9, and 10. The inclusion of endogenous anticoagulants in 4-factor prothrombin complex concentrate appears to reduce the risk of thrombosis compared to products like factor 9 complex. However, prothrombin complex concentrates still pose a warning regarding potential arterial and venous thrombotic complications. Yet, modern formulations are believed to carry a lower risk than older preparations. The mechanism by which prothrombin complex concentrates may reverse the effects of direct factor 10A inhibitors is not fully understood. This is partly because factor levels are typically normal in patients who are receiving these medications. The proposed mechanism suggests that by flooding the system with coagulation factors, it is possible to overwhelm the inhibition caused by these drugs. Evidence supporting the utilization of 4-factor prothrombin complex concentrate and activated prothrombin complex concentrate as hemostatic therapy in patients experiencing major bleeding due to direct factor 10A inhibitors is somewhat limited when compared to andexanet alpha, and much of this evidence is regarded as off-label. Preclinical studies conducted on healthy volunteers and animal models have demonstrated variable effects of 4-factor prothrombin complex concentrate and activated prothrombin complex concentrate on coagulation abnormalities induced by direct factor 10A inhibitors. Some studies revealed a modest correction of laboratory parameters, while others indicated either partial or complete reversal of bleeding times in animal models and healthy volunteers. Nevertheless, certain studies observed no reduction in blood loss, despite some improvement in coagulation parameters. Observational studies conducted on human subjects with major bleeding related to direct factor 10A inhibitors and treated with 4-factor prothrombin complex concentrate exhibit variable rates of hemostatic efficacy, which range from 69% to 85%. A systematic review of case series reflected low rates of bleeding, thromboembolic events, and mortality associated with 4-factor prothrombin complex concentrate. However, these studies frequently lack standardized prospective data collection and control groups, rendering it challenging to ascertain the additional benefits of 4-factor prothrombin complex concentrate beyond supportive measures and the clearance of the drug. When specific direct factor 10A inhibitors are considered, most of the evidence, including clinical trials for andexanet alpha and comparative studies, primarily focuses on apixaban and rivaroxaban, as they are the most commonly used medications. There is available preclinical and observational data, regarding 4-factor prothrombin complex concentrate and activated prothrombin complex concentrate for these two agents. Edoxaban is also referenced in some studies regarding the reversal of direct factor Xa inhibitors. This includes some preclinical work involving 4-factor prothrombin complex concentrate and andexanet alpha studies. However, substantial clinical data supporting reversal strategies in edoxaban-related intracranial hemorrhage using 4-factor prothrombin complex concentrate or activated prothrombin complex concentrate is still lacking. Betrixaban represents a newer direct factor Xa inhibitor, but there is limited data on reversal strategies for this drug beyond its half-life information and mention in some discussions about reversal agents. Fondaparinux, which also acts as a direct factor Xa inhibitor, has its reversal strategies addressed separately from those of oral direct factor Xa inhibitors. Some evidence suggests that activated prothrombin complex concentrate or recombinant activated factor 7A may serve as potential options for fondaparinux. However, the available data is limited, and the use of protamine is recommended against for reversal of fondaparinux. Recent evidence on the comparison of andexanet alpha and 4-factor prothrombin complex concentrate, 4-FPCC, for reversing direct factor Xa inhibitors has emerged, particularly from head-to-head randomized controlled trials. However, earlier insights were primarily derived from retrospective studies and meta-analyses, along with recent findings from the Nexus trial. Early retrospective studies presented a mixed picture. Several smaller studies that evaluated andexanet alpha against 4-FPCC in the context of intracranial hemorrhage associated with direct factor Xa inhibitors demonstrated varying results regarding hemostatic efficacy and clinical outcomes. Many of these studies found no significant differences between the two treatments, likely due to their small sample sizes and potential biases. Some studies reported similar rates of achieving hemostasis, yet there was conflicting data concerning mortality rates and the occurrence of thrombotic events. In larger observational studies, a significant investigation conducted in a large U.S. hospital encompassing over 4,000 patients revealed that treatment with andexanet alpha was associated with a 50% reduction in the odds of in-hospital mortality when compared to 4-FPCC. This analysis focused on patients experiencing major bleeding linked to rivaroxaban or apixaban, which included both intracranial and gastrointestinal bleeds, and was adjusted for relevant risk factors. This study represents the largest observational analysis to date that has compared these two treatment modalities. In terms of meta-analyses, studies mostly comprised retrospective data have attempted to draw comparisons between andexanet alpha and 4-FPCC. Some of these meta-analyses reported no significant differences in hemostatic efficacy, overall mortality, or rates of thromboembolic events. Nonetheless, they often underscored notable heterogeneity among the included studies and acknowledged substantial limitations in the quality of the available evidence. One particular meta-analysis indicated a potentially elevated thromboembolic event rate associated with andexanet alpha compared to 4-FPCC, citing rates of 14% versus 8% respectively. However, a subsequent sub-analysis that conducted a direct comparison between the two interventions did not demonstrate any significant differences. A very recent meta-analysis that incorporated the Nexus randomized controlled trial found no disparities in short-term mortality rates between patients treated with andexanet alpha and those receiving 4-FPCC. Nevertheless, it reported an increased incidence of thromboembolic events associated with andexanet alpha in controlled studies. The Nexus randomized controlled trial is noteworthy as it was the first trial designed to directly compare andexanet alpha to usual care, with 4-factor prothrombin complex concentrate being administered to 53.1% of patients in the usual care group. This study focused on individuals with intracranial hemorrhage associated with direct factor Xa inhibitors and concluded that treatment with andexanet alpha resulted in superior hemostatic efficacy at the 12-hour mark, achieving 67% versus 53.1% respectively. However, the study also indicated that andexanet alpha was linked to a higher occurrence of thrombotic events when compared to usual care. It is important to note that the study excluded the most critically ill patients and had methodological limitations, such as blinding not being implemented among the clinicians involved in treatment decisions. Ultimately, the study did not provide evidence of improved outcomes in terms of patient-oriented clinical results. While it is important to note, as of 2026, andexanet alfa will be removed from the U.S. market. However, it is still relevant to understand its history. Several guidelines recommend using andexanet alfa as a reasonable option for reversing spontaneous intracranial hemorrhage associated with direct factor Xa inhibitors. In situations where andexanet alfa is not available, prothrombin complex concentrate for FPCC or activated prothrombin complex concentrate APCC may be considered to enhance hemostasis. However, the level of evidence supporting the use of 4-FPCC or APCC for direct factor Xa inhibitor reversal is generally lower than that for andexanet alfa. For instance, in some guidelines, andexanet alfa is rated BNR, while 4-FPCC and APCC are rated CLD. Practical considerations regarding these treatments include their availability. Andexanet alfa may not be available in every location, particularly in smaller community hospitals. Therefore, 4-FPCC and APCC become important alternatives in such contexts. Cost is another factor that influences treatment choices. Andexanet alfa is significantly more expensive than 4-FPCC. Physicians have reported that costs can be a reason for not using 4-FPCC in certain situations. The cost-effectiveness of andexanet alfa compared to fresh frozen plasma has also been a topic of debate. Thrombotic risk is an important consideration with both andexanet alfa and prothrombin complex concentrates. Each option carries risks associated with thrombotic events. The risk may be influenced by the patient's underlying prothrombotic state, the specific bleeding scenario, or the reversal agent itself. Some theories suggest that the mechanism for increased thrombosis associated with andexanet alfa could be related to its interaction with tissue factor pathway inhibitor, which results in a temporary increase in thrombin generation. While some studies indicate a higher risk of thrombotic events with andexanet alfa compared to 4-FPCC, other studies do not support this finding. Although andexanet alfa is the specific reversal agent approved by the Food and Drug Administration for the reversal of apixaban and rivaroxaban for FPCC and APCC, are considered reasonable alternatives when andexanet alfa is unavailable for managing major bleeding associated with direct factor Xa inhibitors, especially intracranial hemorrhages. The evidence supporting the use of 4-FPCC or APCC for reversing direct factor Xa inhibitors is not as comprehensive as that for andexanet alfa, primarily deriving from observational studies and preclinical research. Recent comparative studies and meta-analyses have produced conflicting findings regarding efficacy, mortality, and thrombotic risks in comparison to andexanet alfa. This inconsistency emphasizes the importance of carefully considering individual patient factors and the available resources at each institution. Dosing for off-label use of direct factor Xa inhibitor reversal is often determined based on the patient's weight, typically around 50 units per kilogram, or it may be fixed at 2,000 units. However, there is a lack of comprehensive guidelines regarding optimal dosing in this context. Other strategies can be employed to manage direct factor Xa inhibitor reversal. One option is the administration of activated charcoal with a recommended dose of 50 grams within 2 to 4 hours of ingestion of an oral direct factor Xa inhibitor. This approach can help prevent further absorption of the drug. However, it is only suggested for patients who are intubated or have a low risk of aspiration, and it is contraindicated in patients who are experiencing gastrointestinal bleeding. Hemodialysis is generally not an effective method for removing direct factor Xa inhibitors due to their high protein binding properties. In some instances, recombinant activated factor 7A has been investigated for its potential in direct factor Xa inhibitor reversal. However, the evidence supporting its use is weak and inconsistent across various in vitro studies, animal studies, and limited human trials. Moreover, there are concerns regarding an increased risk of arterial thromboembolism associated with the use of recombinant activated factor 7A outside of its approved indications. Thus, it is typically not recommended over prothrombin complex concentrates. The application of fresh frozen plasma in the reversal of direct factor 10A inhibitors is not widely supported. There is minimal data available regarding its efficacy, as the majority of research has focused on prothrombin complex concentrates or specific reversal agents. Furthermore, fresh frozen plasma contains significantly lower concentrations of clotting factors compared to prothrombin complex concentrates. As a result, its use for direct oral anticoagulant reversal is generally not advised by current guidelines and poses risks such as volume overload and transfusion-related acute lung injury. Regarding bleeding associated with direct factor 10A inhibitors, the primary strategies found in literature involve specific reversal with andexanet alpha for apixaban and rivaroxaban, or nonspecific reversal with 4-factor prothrombin complex concentrates, which are used off-label. Andexanet alpha is approved by the Food and Drug Administration and has shown rapid reversal of anti-factor 10A activity, demonstrating effective hemostasis in clinical trials. Nevertheless, its impact on patient-centered outcomes compared to 4-factor prothrombin complex concentrates is still under evaluation in ongoing studies. 4-factor prothrombin complex concentrates are widely available and are used off-label in situations where specific agents are not available. Activated charcoal may also prove beneficial if used promptly to prevent drug absorption after ingestion. Other agents, such as fresh frozen plasma and recombinant activated factor 7A, are generally not recommended for direct factor 10A inhibitor reversal based on the data available. The field is continuously evolving, with ongoing research into both new and existing reversal agents. Direct thrombin inhibitors, specifically dabigatran and bivalirudin, play a significant role in the management of anticoagulant reversal and bleeding. This area is critical when addressing patients on antithrombotic therapy, especially in scenarios involving life-threatening bleeding or when urgent procedures are required. Direct thrombin inhibitors are a specific class of anticoagulants that work by directly inhibiting thrombin, also known as factor 2A. The mechanism of inhibition can either be competitive and reversible, as seen with dabigatran, argatrobin, and bivalirudin, or irreversible, as in the case of desirudin and lepirudin. Dabigatran stands out as the most commonly prescribed oral direct thrombin inhibitor. In contrast, argatrobin and bivalirudin are administered intravenously. Direct thrombin inhibitors are indicated for both the prophylaxis and treatment of venous thromboembolism, acute coronary syndromes, and the prevention of thrombus formation in non-valvular atrial fibrillation. They also serve as alternatives for patients experiencing heparin-induced thrombocytopenia. The pharmacokinetics of direct thrombin inhibitors vary, with renal excretion being a crucial elimination pathway for several agents. Dabigatran is primarily excreted unchanged through the kidneys, accounting for approximately 80% of its elimination. Its half-life typically ranges from 12 to 17 hours in individuals with normal renal function. However, this half-life may increase significantly in patients with reduced renal function. For instance, it can extend to roughly 27 hours in individuals with a creatinine clearance of less than 30 milliliters per minute. Additionally, older age, particularly those over 75 years, is associated with increased concentrations of dabigatran in the bloodstream. Bivalirudin features a shorter half-life of about 25 minutes and is eliminated through a combination of proteolytic cleavage and renal excretion. Its half-life is also prolonged in the context of renal impairment. In contrast, argatrobin is primarily eliminated through the liver with a half-life of approximately 45 minutes. Direct thrombin inhibitors offer predictable pharmacokinetics and fixed dosing. This reduces the need for routine monitoring compared to vitamin K antagonists. However, assessing their anticoagulant effect in urgent situations is complex, Routine coagulation tests can be affected by direct thrombin inhibitors, but their sensitivity varies significantly based on the specific agent and the assay utilized. When evaluating dabigatran, both the activated partial thromboplastin time and the thrombin time are extended. The thrombin time is particularly sensitive to dabigatran, and a normal result can essentially eliminate clinically relevant levels of the drug. Additionally, the diluted thrombin time and eccrine clotting time correlate well with dabigatran levels and can reliably assess the degree of anticoagulation both qualitatively and quantitatively. Despite these useful assays, the diluted thrombin time and eccrine clotting time are often not readily available in a timely manner, which is crucial for emergency decision-making. The manufacturer of dabigatran does not provide recommendations regarding laboratory monitoring. Laboratory monitoring might be suggested for patients with severe renal dysfunction, particularly regarding residual anticoagulant activity. It is important to note that the sensitivity and specificity of the available laboratory assays for predicting hemostasis and outcomes after reversal remain largely unknown. Therefore, relying solely on laboratory parameters to monitor or redose reversal agents is not currently recommended. Instead, management decisions should primarily be guided by the clinical presentation and the severity of bleeding. Viscoelastic hemostatic assays, such as rotational thromboelastometry and thromboelastography, require further investigation in emergency settings. However, it has been confirmed that dabigatran does influence some of the parameters measured by these tests. In patients who are taking direct thrombin inhibitors, reversal strategies must be considered in cases of major bleeding. Major bleeding is defined by specific criteria, including bleeding at a critical site, such as intracranial hemorrhage, hemodynamic instability, or clinically observable bleeding resulting in a significant drop in hemoglobin levels or the need for red blood cell transfusion. Reversal of anticoagulation is also indicated when an urgent surgery or an invasive procedure that poses a significant bleeding risk is required while the anticoagulant is still active in the patient's system. Notably, intracranial hemorrhage is emphasized as a critical site of bleeding that necessitates careful consideration for reversal of the anticoagulant therapy. The first step in managing bleeding associated with direct thrombin inhibitors is to immediately stop the anticoagulant medication. It is important to consider various factors, such as the time elapsed since the last dose was taken and the patient's renal function. These elements are the most useful in estimating the extent of anticoagulation exposure and guiding subsequent therapy. In critical situations, it is essential not to delay the initiation of reversal treatment while waiting for coagulation assay results. Furthermore, activated charcoal can be administered within 2 hours of the recent ingestion of an oral direct thrombin inhibitor, such as dabigatran. This intervention aims to prevent further absorption of the medication, especially in patients who are intubated or those who are at a low risk of aspiration. For dabigatran, a specific antidote is available, idarucizumab. Idarucizumab, also known as Praxbind, is a humanized monoclonal antibody fragment that has a high affinity and specificity for dabigatran. It effectively neutralizes the anticoagulant activity of dabigatran by binding to both free and thrombin-bound forms of the drug. Importantly, idarucizumab binds irreversibly to dabigatran, and the resulting idarucizumab-dabigatran complex is then cleared by the kidneys. Idarucizumab received approval from the Food and Drug Administration in October 2015. It is licensed in both the United States and Europe for the reversal of dabigatran-induced coagulopathy. This is particularly applicable in patients who are experiencing life-threatening or uncontrolled bleeding and in those who require urgent or emergent medical procedures. The REVERSE-AD study, which is a large prospective cohort study, evaluated the efficacy of idarucizumab in patients with uncontrolled bleeding or those requiring urgent procedures. The full cohort analysis included 503 patients, and it demonstrated that a 5-gram intravenous dose administered as 2 separate boluses of 2.5 grams each rapidly and completely reversed the anticoagulant effect of dabigatran in over 98% of patients. This was determined by measurements such as direct thrombin time or activated partial thromboplastin time. The reversal of anticoagulation was maintained for 24 hours in most patients, and the single 5-gram dose was effective in 98% of individuals. In the context of intracerebral hemorrhage, idarusazumab is considered a reasonable option and is recommended for cases associated with spontaneous bleeding due to dabigatran. It received a Class 2A recommendation with a level of evidence BNR in clinical guidelines. The REVERSE-AD study included a subset of patients suffering from intracerebral hemorrhage. While idarusazumab was able to achieve rapid and complete reversal in these cases, the study design, which was single-arm with no requirement for imaging or clinical outcome collection for the hemorrhage subset, limits the ability to draw definitive conclusions about its clinical efficacy in this specific population. Nonetheless, real-world case series have indicated that these patients experience similar mortality rates and an acceptable incidence of thrombotic events, which suggests that there is a potential therapeutic effect. Thrombotic events were observed in 4.8% of patients within 30 days and 6.8% within 90 days of receiving idarusazumab, according to the REVERSE-AD study. These rates were lower than those reported in some studies evaluating prothrombin complex concentrate for vitamin K antagonist reversal. Additionally, they were lower than the rates observed with andexanet alpha in the Nexus 4 study. Thrombosis following the administration of idarusazumab may be attributable to the patient's underlying prothrombotic condition or the circumstances surrounding the bleeding event, rather than being a direct consequence of idarusazumab itself. The recommended dosage of idarusazumab is 5 grams administered intravenously, typically provided as 2 separate vials or boluses of 2.5 grams each. Consideration may be given to redosing if bleeding persists, and there is objective evidence of a residual anticoagulant effect. However, redosing is considered controversial due to the limited evidence supporting its necessity. If idarusazumab is not available for treating dabigatran-associated intracerebral hemorrhage, alternative strategies may be considered. However, these alternatives are less specific, and the evidence supporting their clinical efficacy is not as strong as that for idarusazumab. Prothrombin complex concentrates and activated prothrombin complex concentrates may be options. These agents receive a Class 2B level of evidence CLD recommendation in guidelines. Nevertheless, studies indicate that they have not been formally tested for this indication and do not fully reverse the coagulopathy caused by dabigatran. In vitro and animal studies have shown variable effects in correcting bleeding times and some thrombin generation parameters. However, these agents do not consistently normalize routine coagulation assays. Some in vitro data suggest that activated prothrombin complex concentrate may be slightly more effective than 4-factor prothrombin complex concentrate. Although small case series have implied a potential benefit from using activated prothrombin complex concentrate, these studies were limited by the absence of control groups. Additionally, it is important to consider that activated prothrombin complex concentrate might carry a higher risk of thrombosis in comparison to 4-factor prothrombin complex concentrate. Moreover, certain studies suggest that prothrombin complex concentrate strategies may have limitations in fully restoring hemostasis in patients treated with dabigatran. Hemodialysis is another potential option since dabigatran has a low protein binding rate of 35% and is primarily excreted through the kidneys. This method may be especially significant for patients with renal impairment or when idarusazumab is not available. Hemodialysis receives a Class 2B level of evidence CLD recommendation. It has proven effective in reducing the plasma concentrations of dabigatran. However, it is important to note that a rebound of dabigatran concentration can occur following the cessation of hemodialysis. The impact of hemodialysis on clinical outcomes in cases of dabigatran-associated bleeding remains unclear. For effective elimination, high flow rates during hemodialysis are essential. This procedure also carries risks for patients with intracerebral hemorrhage, including dialysis disequilibrium syndrome, cerebral edema, and elevated intracranial pressure. These risks can make hemodialysis poorly tolerated, particularly in patients with significant mass effect or edema. Consequently, hemodialysis is mainly considered for patients who continue to experience significant bleeding despite initial reversal efforts. The evidence recommends against using fresh frozen plasma and recombinant activated factor VII for treating direct thrombin inhibitor-related intracerebral hemorrhage. This recommendation is based on low-quality evidence. Studies have not consistently shown any benefit from these treatments, and fresh frozen plasma may be minimally effective due to its content of factor II, which is inhibited by direct thrombin inhibitors. Discontinuation is the primary strategy for intravenous direct thrombin inhibitors such as bivalirudin and argatrobin, particularly due to bivalirudin's short half-life. Although ex vivo studies utilizing thromboelastography, TEG, have indicated that recombinant activated factor VIIa effectively reverses the effects of argatrobin and bivalirudin, it is essential to note that there are no widely available specific antidotes for these agents. In instances where reversal is necessary and specific agents are not accessible, prothrombin complex concentrates or activated prothrombin complex concentrates may be considered based on data largely extrapolated from studies focused on dabigatran. The field of anticoagulant reversal is rapidly changing. Siraparantag, known as aripazine, represents a potential universal antidote that is being designed to reverse direct thrombin inhibitors, direct factor Xa inhibitors, and heparins. This antidote is currently in development, with Phase 2 and Phase 3 clinical trials expected to commence shortly. Further research is imperative to clarify the role of coagulation activity assays in identifying patients who would benefit most from specific reversal strategies. For dabigatran reversal, idarusizumab is the recommended first-line agent in situations involving major bleeding or the need for urgent procedures, particularly in cases of intracranial hemorrhage ICH. Idarusizumab has demonstrated a rapid and complete reversal of the anticoagulant effect. In the event that idarusizumab is unavailable, nonspecific agents such as prothrombin complex concentrates or hemodialysis may be considered, guided by the clinical presentation and renal function. It is important to acknowledge the limitations of the current evidence supporting these alternatives compared to the specific antidote. For other direct thrombin inhibitors like bivalirudin and argatrobin, discontinuation remains a crucial strategy. In urgent situations, nonspecific agents might also be considered, although the available evidence supporting their effectiveness is quite limited. Unfractionated heparin is a cornerstone of anticoagulant therapy, and it is crucial to understand how to manage bleeding or the need for medical procedures in patients receiving it. When discussing anticoagulant reversal strategies, unfractionated heparin presents a distinct set of challenges and solutions compared to vitamin K antagonists or the newer direct oral anticoagulants. Understanding unfractionated heparin is essential for effective anticoagulation management. It is a parenteral anticoagulant, meaning it is administered by injection, usually intravenously or subcutaneously. The primary mechanism of action involves binding to and activating antithrombin 3. This activation significantly accelerates the ability of antithrombin to inactivate key clotting factors, most notably thrombin and factor Xa. Unfractionated heparin also influences factors 9, 11, 12, and plasmin, ultimately preventing the formation of fibrin. The anticoagulant effect of unfractionated heparin is typically monitored using the activated partial thromboplastin time. Although it can affect other tests, such as thrombin time and anti-factor Xa levels, activated partial thromboplastin time is the standard for monitoring therapeutic doses of unfractionated heparin. The half-life of unfractionated heparin is relatively short, ranging from 1 to 2 hours or approximately 60 to 90 minutes, which is a significant factor in its management. Unfractionated heparin is indicated for various conditions that require anticoagulation. These include both the treatment and prevention of venous thromboembolism and prophylaxis for mechanical heart valves. Bleeding risk is an important consideration with unfractionated heparin. Like all anticoagulants, it carries a risk of bleeding. intracranial hemorrhage can occur, although the incidence in patients receiving intravenous unfractionated heparin for non-neurological reasons is relatively low, estimated to be between 0 to 0.1%. In cases of bleeding or when urgent reversal of unfractionated heparin UFH is required, the primary strategy is to utilize a specific antidote known as protamine sulfate. Protamine sulfate serves as the specific reversal agent for UFH. The mechanism by which protamine works is quite fascinating. It is a basic protein derived from fish sperm, which binds to the negatively charged heparin molecule. This interaction forms a stable, inactive salt that effectively neutralizes the anticoagulant effect of heparin. The indications for the use of protamine sulfate should also be noted. While it is often sufficient to discontinue the heparin infusion for many bleeding events, protamine is recommended in cases of severe bleeding, such as heparin-associated intracranial hemorrhage. Furthermore, protamine is also used when urgent reversal is needed for certain procedures. Urgent reversal is particularly crucial for patients who develop intracranial hemorrhage while receiving a full-dose heparin infusion. Routine reversal of prophylactic subcutaneous UFH is generally not recommended. However, it may be considered if the activated partial thromboplastin time is significantly prolonged. Dosing for UFH reversal using protamine is based on the amount of UFH that has been administered recently. For patients receiving intravenous UFH, a recommended dosing is 1 milligram of protamine for every 100 units of UFH given over the preceding 2 to 3 hours. It is critical to ensure that the maximum single dose of protamine does not exceed 50 milligrams. In cases where the amount of UFH administered in the last 2 hours is uncertain, a single dose of 25 milligrams of protamine may be given. When it comes to administration, protamine should be administered slowly via intravenous route. This is typically done over a period of 15 minutes. Some evidence suggests that a maximum administration rate should not exceed 5 milligrams per minute or should occur over approximately 10 minutes. Rapid administration can carry the risk of severe side effects, including hypotension, bradycardia, and anaphylactoid reactions. The duration of action of protamine is approximately 2 hours. If the activated partial thromboplastin time remains elevated after the initial dose, repeat administration of protamine at a reduced dose may be considered. For instance, a dosage of 0.5 milligrams per 100 units of UFH may be suggested. However, caution is warranted since excessive protamine can paradoxically result in coagulopathy or increase anticoagulation. In terms of efficacy, studies have shown that protamine effectively neutralizes the activity of UFH and can improve laboratory parameters like the activated partial thromboplastin time. It has also been associated with a reduction in bleeding and transfusion needs in certain surgical settings. Nevertheless, it is important to note that one specific study found that despite the laboratory correction achieved by protamine, the total surgical blood loss did not significantly differ from a control group. Other agents that have been considered for the reversal of unfractionated heparin UFH include fresh frozen plasma and prothrombin complex concentrates. However, these agents are not typically recommended or used for reversing UFH. The specific and effective antidote for this purpose is protamine. Recombinant activated factor 7A has also been evaluated for its efficacy in reversing the effects of UFH. While it has demonstrated some effectiveness in animal studies and certain case reports conducted ex vivo, its advantages over protamine remain unproven. Moreover, there is a significant risk of thrombosis associated with its use. For these reasons, recombinant activated factor 7A is generally not recommended for routine UFH reversal. Siraparantag is another investigational agent that has been designed as a universal antidote. This agent has the potential to reverse the effects of unfractionated heparin as well as other anticoagulants. General management of anticoagulation and the process of restarting therapy are critical components in the treatment of patients experiencing bleeding complications associated with unfractionated heparin UFH. The first step in managing UFH-associated bleeding is to immediately discontinue the infusion. This action is essential to halt further complications. Following the cessation of the anticoagulant, immediate supportive care and source control measures, such as compression and surgery, become vital alongside any reversal strategies that may be implemented. The decision to restart anticoagulation therapy after a bleeding event demands careful consideration, weighing the risk of rebleeding against the patient's inherent thrombotic risk. A reasonable strategy involves the temporary use of prophylactic doses of parenteral anticoagulants. Subcutaneous administration of UFH or low molecular weight heparin LMWH, combined with close monitoring, may effectively manage both rebleeding and thrombotic risks. Notably, a study involving patients with spontaneous intracerebral hemorrhage (ICH) indicated that initiating low-dose subcutaneous heparin prophylaxis as early as day 2 significantly reduced the incidence of pulmonary embolism without causing an increase in rebleeding. This was particularly effective when strict avoidance of rebleeding risk factors, such as uncontrolled hypertension or heparin overdose, was maintained. Among non-ambulatory ICH patients, prophylaxis against venous thromboembolism (VT) is recommended, with the use of intermittent pneumatic compression indicated from the day of diagnosis. In the case of critically ill patients, the presence of underlying conditions like cirrhosis or disseminated intravascular coagulation (DC) can complicate the coagulation status. Traditional coagulation tests, such as the International Normalized Ratio (INR), may not provide a complete picture in these instances. In such complex cases, viscoelastic testing, including thromboelastography or rotational thromboelastometry, may offer a more precise assessment to guide management decisions. For patients receiving unfractionated heparin, the primary strategy for urgent reversal in cases of significant bleeding involves the prompt administration of protamine sulfate. This medication must be carefully dosed and administered slowly to achieve effective neutralization of heparin's effects while minimizing associated risks. The discontinuation of the infusion and supportive care remains a fundamental component of successful management in these critical scenarios. Let's discuss the insights the provided evidence offers regarding the management of bleeding associated with low molecular weight heparin, such as enoxaparin, dalteparin, and nadroparin, while placing this discussion within the broader context of anticoagulant reversal and hemostatic strategies. This framework involves understanding the approach to a class of widely used parenteral anticoagulants. Low molecular weight heparins are a type of parenteral anticoagulant employed for the prophylaxis and treatment of venous thromboembolism, acute pulmonary embolism, and the prevention of venous thromboembolism following specific surgical procedures. These anticoagulants work by binding to and activating antithrombin, which subsequently inhibits coagulation factors, primarily factor Xa, and to a lesser extent, factor 2A or thrombin. They are often preferred over unfractionated heparin due to their more predictable pharmacokinetics and superior bioavailability. Additionally, low molecular weight heparins are primarily eliminated by the kidneys. While low molecular weight heparins may pose a lower overall risk of bleeding compared to unfractionated heparin in certain contexts, the potential for bleeding, particularly intracranial hemorrhage, remains a significant concern. This is especially true for patients suffering from critical neurological illnesses, where the risk of bleeding may be greater than in other patient populations. When bleeding occurs in a patient receiving low molecular weight heparin, particularly in the case of intracranial hemorrhage, swift action is required. The first crucial step when intracranial hemorrhage is present or suspected in a patient receiving low molecular weight heparin is to discontinue the medication. Furthermore, for patients who develop intracranial hemorrhage while on therapeutic doses of low molecular weight heparin, urgent reversal of anticoagulation is strongly recommended. The approach to reversing low molecular weight heparin LMWH effects differs significantly from the methods used for vitamin K antagonists (VKs) or direct oral anticoagulants (DOACs). It primarily relies on an agent that binds to heparin compounds, specifically protamine sulfate. Protamine sulfate is the most commonly used agent for the reversal of LMWH effects. However, it is essential to understand that there is currently no specific reversal agent for LMWHs that completely neutralizes their effects. Protamine is a basic protein that binds to the acidic heparin molecules, forming a stable salt and effectively neutralizing their anticoagulant activity. Despite its utility, the ability of protamine to reverse LMWH effects is variable and often incomplete. This variability significantly depends on the molecular weight and sulfate charge density of the specific LMWH formulation. Protamine is generally more effective at neutralizing the anti-2A activity of LMWH than its anti-10A activity. For instance, in one study conducted in vitro, protamine reversed 99% of the anti-2A effect, but only 40% of the anti-10A effect of tinzaparin. Furthermore, it reversed 64% of the anti-2A activity and 35% of the anti-10A activity of enoxaparin. The administration of protamine for the reversal of LMWH effects is performed through slow, intravenous injection over a period of approximately 10 minutes. Dosing recommendations for protamine are based on the specific LMWH used, the dose that was administered, and the time elapsed since the last dose. In the case of enoxaparin, if the last dose was given within 8 hours, 1 milligram of protamine should be administered per 1 milligram of enoxaparin, with a maximum single dose of 50 milligrams. If the last dose was given 8 to 12 hours prior, the dose is reduced to 0.5 milligrams of protamine per 1 milligram of enoxaparin, still with a maximum single dose of 50 milligrams. For reversal more than 12 hours after dosing, the utility is minimal. For dalteparin, nadroparin, and tinzaparin, the recommended dose is 1 milligram of protamine per 100 anti-10A units of the LMWH administered within the past 3 to 5 half-lives of the drug, with a maximum single dose of 50 milligrams. Redosing of protamine, typically at a rate of 0.5 milligrams per 100 anti-10A units or per 1 milligram of enoxaparin, may be considered if life-threatening bleeding persists or in patients with renal insufficiency. It is not recommended to routinely reverse protamine in patients receiving prophylactic doses of LMWH for intracranial hemorrhage. However, reversal may be considered for prophylactic subcutaneous heparin if the activated partial thromboplastin time is significantly prolonged. Recombinant activated factor 7A is a hemostatic agent known to promote thrombin generation. Most literature suggests that it may be effective in reversing the effects of low molecular weight heparins, also known as LMWHs. Ex vivo studies utilizing thromboelastography indicate that it might successfully reverse the effects of enoxaparin. Additionally, it has been demonstrated that this agent significantly reduces anti-factor 10A levels in patients receiving enoxaparin. Nevertheless, recombinant activated factor 7A is associated with a high risk of thrombosis and is considerably more expensive than other treatment strategies. As a result, it should generally be reserved for specific situations, such as when protamine is contraindicated or in cases of LMWH-related bleeding that do not respond to protamine. The use of this agent outside of approved indications, such as in patients with hemophilia, carries an increased risk of arterial thromboembolism. Some evidence suggests that recombinant activated factor 7A, typically dosed at 90 micrograms per kilogram via intravenous administration, should be considered if protamine is contraindicated. Regarding fresh frozen plasma, prothrombin complex concentrates, and activated prothrombin complex concentrates, it is recommended that these not be used for reversing LMWH. These agents have not demonstrated improvements in anti-10A or anti-2, activity in plasma that has been exposed to LMWHs in laboratory studies. When considering hemodialysis, since LMWHs are primarily eliminated through the kidneys and may bioaccumulate in patients with renal insufficiency, the potential for using hemodialysis for acute reversal arises. However, current literature and evidence suggest that the effectiveness of hemodialysis in the acute removal of LMWH is uncertain and may vary based on the characteristics of the specific LMWH. Some studies indicate limited removal, while others show elimination over time. Therefore, hemodialysis is not recommended as a routine reversal strategy for LMWH. Danopiroid, while not an LMWH, is a related heparinoid available outside the United States. It cannot be reversed by protamine, prothrombin complex concentrates, fresh frozen plasma, or activated prothrombin complex concentrates. Recombinant activated factor VII-A may be considered for intracranial hemorrhage related to danopiroid. Investigational agents such as siraparantag, also known as aripazine, are being studied as potential universal antidotes that could reverse LMWHs, unfractionated heparins, and direct oral anticoagulants. However, data from randomized clinical trials involving bleeding patients are required to clarify the role of these agents. Managing bleeding in patients on LMWHs, particularly in cases of intracranial hemorrhage, primarily involves discontinuing the LMWH and promptly administering protamine sulfate at therapeutic doses. It is important to acknowledge that protamine provides only partial and variable reversal. The use of other agents such as fresh frozen plasma, prothrombin complex concentrates, and activated prothrombin complex concentrates is generally not recommended for LMWH reversal. While recombinant activated factor VII-A may have some utility in specific refractory cases, its use is limited by the risk of thrombosis. Typically, routine reversal is not necessary for prophylactic doses of LMWH. Careful monitoring and clinical assessment remain essential in these situations. Antiplatelet agents, including medications such as aspirin, clopidogrel, prasugrel, and ticagrelor, play a crucial role in therapeutic strategies, especially in the context of bleeding events. This topic is of critical significance in clinical practice because these drugs are widely utilized. Their associated risk of bleeding, particularly intracranial hemorrhage, poses considerable challenges for healthcare practitioners. Antiplatelet agents function by interrupting the hemostatic process primarily through the reduction of platelet aggregation via different mechanisms. For instance, aspirin works as an irreversible inhibitor of cyclooxygenase 1 and 2. Clopidogrel and ticagrelor, classified as adenosine diphosphate receptor inhibitors, offer different characteristics. Ticagrelor is known for being reversible. Other examples include prasugrel, dipyridamole, and glycoprotein 2b3A inhibitors such as eptifibatide and tirofiban. These medications are commonly prescribed for critical indications like the prevention of cardiovascular events, stroke prevention, and both the treatment and prevention of thrombosis. Nevertheless, there is a significant risk associated with antiplatelet therapy, which is bleeding. Previous use of antiplatelet agents has been associated with adverse outcomes in cases of intracranial hemorrhage. This involvement can potentially lead to increased growth and volume of hematomas. When a patient receiving antiplatelet therapy experiences bleeding, particularly in the case of intracranial hemorrhage, the first action taken is generally to cease the administration of the antiplatelet agent. Now, let us examine the specific strategies and agents discussed in the literature regarding the reversal or mitigation of the effects of antiplatelet agents. One such strategy is platelet transfusion, which has historically been viewed as a potential method for reversing the effects of antiplatelet agents, particularly in the context of spontaneous intracerebral hemorrhage, ICH. However, the existing literature advises strong caution against the routine use of platelet transfusion in this setting, especially when the patient's platelet count is otherwise adequate. Several reasons have been cited for the avoidance of platelet transfusion. For instance, residual drugs from antiplatelet agents can inhibit the activity of transfused platelets. Moreover, due to changes occurring during storage, transfused platelets may not perform as effectively as native platelets. Additionally, dysfunctional native platelets could interfere with the function of the transfused platelets. There are several risks associated with platelet transfusion. These include the potential for transfusion reactions, transfusion-related acute lung injury, cytokine release, infections, and suppression of native platelet production. In many cases, these risks may outweigh any potential benefits of the transfusion. Evidence from various studies suggests that platelet transfusion often does not lead to a significant improvement in platelet function. A pivotal study, known as the PATCH trial, which was a major randomized controlled trial involving patients with spontaneous ICH who were taking antiplatelet agents primarily consisting of aspirin, found no notable benefits from platelet transfusion. In fact, patients who received transfusions in this trial experienced worse neurological outcomes and exhibited a trend toward increased bleeding. This trial has been deemed enormously important in shaping treatment guidelines. Current guidelines, which take into account the findings of the PATCH trial, generally recommend against the routine use of platelet transfusion for patients with spontaneous intracerebral hemorrhage who are not undergoing a neurosurgical procedure. There are some expert opinions that claim platelet transfusions are potentially harmful and should not be administered to patients on aspirin who are not scheduled for emergency surgery. There are limited exceptions where platelet transfusion may be considered. This is particularly true for patients on irreversible inhibitors such as aspirin, clopidogrel, or prasugrel. Among these agents, it is theoretically most effective for aspirin due to its mechanism of action. For clopidogrel, however, its receptor blockade and moderate half-life make it potentially less effective. Transfusion is not expected to be beneficial for patients taking reversible inhibitors like ticagrelor, as the transfused platelets would also be inhibited by the circulating drug. Platelet transfusion may be considered if the last dose of the antiplatelet medication was taken more than 3 half-lives ago, or if laboratory evidence of platelet inhibition is available. It may also be warranted in cases of significant ongoing bleeding or planned surgical procedures. Furthermore, if the platelet count is low, such as below 150,000, it is important to note that managing thrombocytopenia is different from reversing antiplatelet function, provided the platelet count remains adequate. For patients on aspirin who require emergency neurosurgery for spontaneous intracerebral hemorrhage, platelet transfusion may be beneficial to reduce postoperative bleeding and mortality. However, this recommendation is conditional and based on low-quality evidence. It may be considered in specific cases where other measures, such as the reversal of oral anticoagulants, have failed. Effective reversal of the effects of antiplatelet agents might require a substantial quantity of platelets, generally around 2 to 3 of Ferris's platelet units. DAVP is a synthetic analog of vasopressin that stimulates the release of von Willebrand factor and factor VIII from the endothelium. Von Willebrand factor binds to platelet receptors, specifically glycoprotein 2b3a. This binding improves platelet adhesion and aggregation in a nonspecific manner. DAVP may be particularly effective in patients with pre-existing deficiencies of von Willebrand factor or factor VIII. A common suggested dosage of DAVP is between 0.3 and 0.4 micrograms per kilogram, infused over a duration of 20 to 30 minutes. A single intravenous dose of 0.4 micrograms per kilogram is conditionally recommended for antiplatelet reversal in the setting of intracerebral hemorrhage. Evidence suggests that DAVP can enhance platelet function in vitro and in specific clinical scenarios, such as in patients with uremia or those undergoing cardiac surgery while on aspirin, as it can reduce blood loss. Additionally, it has been shown to improve platelet activity in cases of acute intracerebral hemorrhage. However, the effectiveness of DAVP in reducing hematoma expansion in patients with antiplatelet-associated spontaneous intracerebral hemorrhage remains uncertain, as there are conflicting reports in the literature. Some studies have shown no significant difference in hematoma expansion attributable to DAVP. Possible reasons for the lack of observed benefit in some studies include the short duration of DAVP's effect, which may last only hours, and the potential confounding effects of concomitant platelet transfusions in various studies. In terms of safety and risks, DAVP carries potential adverse effects, including hyponatremia, tachycardia, and headache. There are also conflicting reports regarding its potential to increase thrombotic events. One study found that the administration of DAVP was not associated with an increased incidence of thrombotic events. clinicians should be cautious of these risks and closely monitor patients, particularly those with a recent history of myocardial infarction or ischemic stroke. Tranexamic acid and epsilon aminocaproic acid are antifibrinolytic agents. Some evidence suggests that tranexamic acid can enhance platelet function in vitro among patients who are receiving antiplatelet therapy. Additionally, it may help to reduce operative blood loss in patients undergoing coronary artery bypass grafting who are also taking antiplatelet medications. However, in the context of intracerebral hemorrhage, clinical trials, including the TICA-2 trial, have generally not demonstrated safety or significant benefit. Overall, the existing evidence does not provide strong support for the use of tranexamic acid or epsilon aminocaproic acid specifically for reversing the effects of antiplatelet therapy in cases of intracerebral hemorrhage. Fibrinogen supplementation, such as cryoprecipitate, is based on the understanding that platelets and fibrinogen work together to form a clot. Increasing fibrinogen levels may compensate for dysfunction in platelets. In vitro studies indicate that elevating fibrinogen can enhance clot firmness in blood that has been treated with antiplatelet agents. Additionally, fibrinogen supplementation has been shown to improve platelet aggregation in vitro when used alongside glycoprotein 2b3A inhibitors. However, there is minimal evidence supporting the use of fibrinogen specifically to counteract the effects of antiplatelet agents in cases of clinical bleeding, making such evidence nearly non-existent. For hemorrhaging patients on antiplatelet medication, it may be advisable to target a slightly higher fibrinogen level, aiming towards 200 milligrams per deciliter, although the optimal target remains a topic of debate. The application of cryoprecipitate could be considered in cases of intracerebral hemorrhage related to glycoprotein 2b3A, but it is important to note that there is limited literature supporting this approach. Literature suggests checking fibrinogen levels after administering other reversal agents, and then considering cryoprecipitate if the levels fall below 150 milligrams per deciliter. Regarding recombinant activated factor 7A, while it can potentially influence coagulation, there is evidence that advises against its use for reversing vitamin K antagonists in cases of intracerebral hemorrhage due to a lack of substantial benefit. When combined with other agents, recombinant activated factor 7A may also heighten the risk of thrombotic events. Expert opinions do not strongly endorse or recommend recombinant activated factor 7A for general reversal of antiplatelet effects in cases of intracerebral hemorrhage, despite existing in vitro evidence supporting its ability to counteract the effects of aspirin. Patients who are taking both oral anticoagulants (OAC) and antiplatelet agents may face an increased risk of severe or prolonged bleeding. Therefore, the decision to discontinue concomitant antiplatelet agents should carefully weigh the associated risks against the benefits. In cases involving irreversible antiplatelet agents, a temporary cessation may not be clinically effective for several days. If the patient is not hospitalized for bleeding or procedures and hemostasis is successfully achieved, it may be reasonable to continue both types of medication. When addressing uremic platelet dysfunction, desmopressin at a dose of 0.3 milligrams per kilogram may be considered for managing platelet dysfunction linked with severe uremia. However, it is important to note that evidence specifically related to intracerebral hemorrhage (ICH) remains limited. Thrombocytopenia presents another concern. For patients with a low platelet count, defined as less than 50,000 per milliliters or less than 100,000 per milliliters prior to neurosurgery, platelet transfusion is indicated to elevate the count. This situation is distinct from transfusing platelets to reverse antiplatelet function when the platelet count is normal. The existing evidence and literature provide cautious and sometimes conflicting guidance concerning the reversal of antiplatelet agents in the context of bleeding. Although discontinuing the antiplatelet agents is the initial step, the effectiveness of specific reversal agents remains a topic of debate. Platelet transfusion, despite its historical use, is strongly discouraged for routine application in cases of spontaneous intracerebral hemorrhage due to a lack of demonstrated benefit and the potential for harm as indicated in the patch trial. While desmopressin appears to show promise in enhancing platelet function and reducing bleeding in certain surgical settings, its efficacy in decreasing hematoma expansion or improving outcomes in instances of antiplatelet-associated intracerebral hemorrhage remains uncertain according to current evidence. Other agents, such as tranexamic acid and recombinant activated factor 7A, are generally not recommended for this particular indication. Decisions regarding reversal strategies must be tailored to the individual patient, taking into account the clinical situation, the specific antiplatelet agent being used, the type and severity of the bleeding, and the availability of reversal agents within the institution. Acknowledging the limitations of the current evidence is crucial in this decision-making process. Further research, particularly involving randomized controlled trials, is necessary to clarify the optimal management strategies for these complex situations. This class of medications, which includes agents such as alteplase, reteplase, and tenecteplase, plays a crucial role in the treatment of various acute thrombotic conditions. However, their mechanism of action inherently carries a risk of bleeding, which necessitates the development of specific reversal strategies. Fibrinolytic agents function primarily as plasminogen activators. Their key mechanism involves catalyzing the conversion of plasminogen to plasmin. Plasmin is the enzyme responsible for degrading fibrin, the protein that forms the structural network of blood clots. These agents are categorized based on their selectivity. Fibrin non-selective agents degrade both fibrinogen and fibrin, while fibrin-selective agents preferentially degrade fibrin when fibrinogen is present. In addition to their role in clot lysis, these agents have other proteolytic effects. They include the cleavage of platelet glycoproteins GPI, 2A, and GP1B, which leads to the inhibition of platelet function. Depending on the administered dose, fibrinolytic agents can cause a significant breakdown of fibrinogen. This results in low serum fibrinogen levels and elevated levels of fibrin degradation products. This phenomenon, combined with platelet dysfunction, contributes to a systemic anticoagulant state that can promote hemorrhage. Common indications for the use of thrombolytic agents include acute ischemic stroke, massive pulmonary embolism, and ST elevation myocardial infarction. However, the use of these agents is associated with a significant risk of bleeding, particularly intracranial hemorrhage. Managing bleeding in patients receiving these agents requires prompt and effective intervention. When managing bleeding in a patient who has received a fibrinolytic agent, the primary strategies focus on stopping the ongoing fibrinolysis and replacing the depleted clotting factors, particularly fibrinogen. The first and most critical step in addressing bleeding associated with thrombolytics, especially if there is a suspicion of intracranial hemorrhage, is to immediately discontinue the fibrinolytic infusion. This action is considered a best practice. It is crucial to recognize that, unlike some other anticoagulants such as dabigatran or factor Xa inhibitors, no specific reversal agents are available for thrombolytics. Thus, management primarily relies on general hemostatic strategies and allows for the natural clearance of the drug from the system. Thrombolytics can significantly degrade fibrinogen, leading to low levels of this important protein. Low fibrinogen levels are slow to correct spontaneously and are associated with hematoma expansion, particularly in cases of intracranial hemorrhage. Therefore, replacing fibrinogen becomes an essential component of treatment. Cryoprecipitate is the recommended therapy for correcting low fibrinogen levels in patients experiencing thrombolytic-associated intracranial hemorrhage. Cryoprecipitate contains fibrinogen in a more concentrated form compared to plasma, meaning a smaller volume is required for administration. If the fibrinogen level is less than 150 milligrams per deciliter, the administration of cryoprecipitate is suggested. Fresh frozen plasma can also serve as a source of fibrinogen. However, it contains fibrinogen in a lower concentration than cryoprecipitate, requiring a larger volume to achieve adequate fibrinogen levels. Consequently, Cryoprecipitate is preferred over fresh frozen plasma for this purpose. Studies examining fresh frozen plasma for thrombolytic-associated intracranial hemorrhage have not demonstrated a correlation with hematoma expansion or improved outcomes. Managing patients on anticoagulant therapy requires a delicate balance. On one hand, it is essential to prevent potentially devastating thrombotic events. On the other hand, it is necessary to mitigate the inherent risk of bleeding. When bleeding occurs, especially if it is major bleeding, a rapid assessment is crucial. Appropriate interventions must then be initiated, which may include a temporary cessation of the anticoagulant and providing supportive care. Reversal strategies should be employed based on the specific anticoagulant involved and the severity of the bleeding. These strategies may utilize agents such as prothrombin complex concentrates or specific antidotes, all aimed at restoring hemostasis. After the successful management of the bleeding event and the stabilization of the patient, a critical decision point arises. Clinicians must consider whether and when to restart anticoagulation therapy. This decision is inherently complex and necessitates a careful consideration of multiple factors. It involves balancing the patient's risk of future thromboembolic events against the potential risk of rebleeding. The decision to restart anticoagulation is generally recommended in most cases, as the net clinical benefit often favors resuming therapy. However, this is not a universal rule and requires an individualized approach, taking into account several important factors. First, it is essential to consider the original indication for anticoagulation and the associated thrombotic risk. The reason the patient was prescribed anticoagulation, such as for mechanical heart valve, atrial fibrillation, or venous thromboembolism, serves as a primary determinant of whether therapy should be resumed. Patients with a high thrombotic risk due to their underlying conditions are more likely to benefit from restarting anticoagulation, despite the risk of rebleeding being high. For example, individuals with non-valvular atrial fibrillation face a significant mortality risk without anticoagulation. Similarly, patients with a mechanical valve or a left ventricular assist device present with high thrombotic risk, making early resumption of anticoagulation reasonable. The characteristics of the bleeding event should also influence this decision. The location of the bleeding is critical. For instance, bleeding at significant sites such as intracranial hemorrhage significantly impacts the decision and timing for restarting anticoagulation. Lobar intracranial hemorrhage, which suggests amyloid angiopathy, and spontaneous subdural hematomas carry a particularly high risk of rebleeding. Furthermore, whether the source of the bleeding was definitively identified and successfully treated also affects the risk of recurrence. The mechanism of bleeding, whether it was traumatic or spontaneous, may additionally play a role, as might the severity of the bleeding. Classifying the bleeding as major or non-major can influence initial management and subsequent decisions regarding the resumption of anticoagulation. Moreover, patient-specific factors and pre-existing comorbidities must be considered. Any reversible contributing factors that may have led to the bleeding should be addressed before restarting anticoagulation. For example, if the bleeding was due to supertherapeutic international normalized ratio in patients taking vitamin K antagonists or acute renal insufficiency, leading to elevated levels of direct oral anticoagulants, these issues must be resolved. Impaired renal or hepatic function can significantly affect the metabolism and excretion of anticoagulants, which in turn influences drug and dose selection upon restarting therapy. Additionally, the need for concurrent antiplatelet therapy should be reevaluated based on the patient situation. Factors such as frailty and other active medical issues can also influence the patient's overall risk profile. Planned surgical or invasive procedures may necessitate delaying the restart of anticoagulation. Finally, patient engagement and shared decision-making should be emphasized during this process. Open discussions with the patient and their family are crucial to outline the risks and benefits associated with restarting anticoagulation therapy. It is important that the preferences of the patient are considered when arriving at a decision. If initial measures have not controlled the bleeding, then restarting anticoagulation would be inappropriate. Determining the optimal timing for reinitiating oral anticoagulation is a matter that lacks systematic study and shows significant variability. The primary objective is to strike a balance between preventing thrombotic events and managing the risk of rebleeding. For patients classified as having a high thrombotic risk, it is generally advantageous to reinitiate anticoagulation as soon as hemostasis is achieved and the patient is considered stable. In cases where patients are at high risk for rebleeding, but also face an unacceptably elevated thrombotic risk, it may be prudent to consider the initial use of unfractionated heparin administered by intravenous infusion. This approach is beneficial due to the anticoagulant's short half-life and the availability of rapid reversal with protamine sulfate. Under close monitoring, parenteral anticoagulants can occasionally be initiated within 1 to 3 days for these patients. In situations involving non-major bleeding, it is often advisable to temporarily hold the oral anticoagulant until stability and hemostasis are adequately achieved. However, routine reversal of anticoagulation is not generally supported. If a valid indication for continued anticoagulation exists, the oral anticoagulant should be restarted once the concerns regarding potential further bleeding complications have been resolved. Gastrointestinal bleeding is a common complication that often arises in clinical practice. Once hemostasis is achieved, it is generally considered reasonable to resume anticoagulation. Observational studies indicate that restarting anticoagulation is associated with a lower risk of thromboembolism and mortality, although it does carry an increased risk of recurrent bleeding. The optimal timing for resuming anticoagulation has not been systematically studied. However, some evidence suggests that delaying the restart of warfarin for more than 7 days after a bleeding episode may enhance survival and reduce the risk of thromboembolism, without significantly increasing the chances of recurrent gastrointestinal bleeding. Intracranial hemorrhage is a serious complication that necessitates a cautious and individualized approach. There is limited data available regarding the resumption of anticoagulation after an incident of intracranial hemorrhage. Various factors, including lobar location related to amyloid angiopathy and the presence of microbleeds, increase the risk of hemorrhage recurrence and require a careful evaluation, often in consultation with neurology or neurosurgery specialists. For most cases of spontaneous intracranial hemorrhage, delaying the resumption of anticoagulation for at least 4 weeks in patients who do not present a high thrombotic risk is generally preferred. Observational studies focusing on warfarin-associated intracranial hemorrhage suggest that resuming anticoagulation may reduce the risks of thrombosis and death without significantly increasing the likelihood of rebleeding. It is noteworthy that the median time to restart anticoagulation was approximately 1 month. Current medical guidelines recommend avoiding the use of anticoagulation for at least 4 weeks in patients who do not have mechanical heart valves, and they suggest considering aspirin monotherapy initially if deemed necessary. In the context of surgical procedures, if anticoagulation was halted or reversed prior to a procedure without any preceding bleeding, and if adequate hemostasis is achieved post-procedure, it is advisable to restart anticoagulation promptly. For procedures that carry a low risk of post-procedural bleeding, it is usually appropriate to resume anticoagulation after 24 hours. In cases with a higher risk of bleeding, the initiation of therapeutic dose anticoagulation may be delayed for 48 to 72 hours. For high-risk patients who are restarting vitamin K antagonist therapy after a temporary discontinuation, bridging anticoagulation with parenteral agents may be considered. However, this approach is associated with an increased risk of bleeding and does not reduce thrombotic events in patients with non-valvular atrial fibrillation. Bridging should not be implemented if a direct oral anticoagulant is used after the procedure. If surgical intervention was performed to address bleeding, the timing for resuming anticoagulation depends on the characteristics of the bleed and the success of the surgical intervention. Individualized strategies, alongside close monitoring, are essential if bleeding was not successfully controlled. When restarting anticoagulation, it is essential to re-evaluate the appropriate anticoagulant and dosage. This evaluation should consider several factors, including the patient's indication for treatment, age, weight, and renal function. Such careful consideration is important to minimize the risk of adverse events. If a reversible cause related to the previous oral anticoagulant contributed to the bleeding, switching to an alternative oral anticoagulant may be advisable. For instance, a high international normalized ratio on vitamin K antagonists or variations in renal function affecting direct oral anticoagulants could warrant a change. Close monitoring is highly recommended upon reinitiating treatment. In summary, while aggressive management and reversal of anticoagulation are critical in cases of acute bleeding, the decision to restart anticoagulant therapy requires a complex risk-benefit assessment. This assessment must be individualized, taking into account the patient's risk of thrombosis, the nature of the bleed, and their overall clinical status. This decision-making process is often informed by expert consensus and should involve shared discussions between the healthcare provider, the patient, and their family. Here is a summary of the key points regarding the reversal of anticoagulants and antiplatelet medications in urgent clinical situations. A general consideration is to gain a comprehensive understanding of the patient's coagulopathy by taking into account various factors and medications they may be taking. It is important to note that critically ill patients often experience several coagulopathies simultaneously. Traditional coagulation tests, such as the International Normalized Ratio, INR, and Activated Partial Thromboplastin Time, APTT, may fail to accurately reflect the true coagulation status, particularly in specific patient populations. Viscoelastic assays, like thromboelastography and rotational thromboelastometry, can evaluate both cellular and plasma components of clot formation and may provide more accurate results in critically ill patients as well as those with liver cirrhosis. However, the usefulness of viscoelastic assays in guiding decisions regarding the reversal of direct oral anticoagulants and their correlation with clinical outcomes remains under research. In cases of major bleeding associated with oral anticoagulants, it is crucial to immediately discontinue these medications. Additionally, proper airway management and intravenous access must be secured. Local hemostatic measures should be initiated along with resuscitation efforts. It is recommended to reverse the effects of oral anticoagulants if a reversal agent is available for most major bleeding events, but it is vital not to delay resuscitation in doing so. Furthermore, it is essential to correct any hypothermia or acidosis, as these factors exacerbate coagulopathy. It is also necessary to address any comorbidities, including the presence of antiplatelet therapy, thrombocytopenia, uremia, and liver disease. Warfarin, which is a vitamin K antagonist, inhibits several coagulation factors, including factors 2, 7, 9, and 10, as well as protein C and S. Intracerebral hemorrhaging associated with warfarin use has a higher frequency, larger hematoma volume, and increased rates of mortality and morbidity. Traditional monitoring via INR is commonly employed for warfarin. However, it may not be reliable in critically ill patients. If bleeding occurs, particularly in the case of intracerebral hemorrhage, discontinuation of warfarin should happen immediately. Urgent reversal for vitamin K antagonist-associated intracerebral hemorrhage is strongly advised and should ideally begin without waiting for INR results. The administration of 10 milligrams of intravenous vitamin K serves as a specific reversal agent for vitamin K antagonists. While it provides the substrate necessary for the synthesis of coagulation factors and contributes to lasting reversal, its effect is not immediate. The preferred agent for rapid reversal in major bleeding events or urgent procedures is 4-factor prothrombin complex concentrate. This agent is favored due to its lower volume, quicker administration time, and more consistent and rapid INR reversal compared to fresh frozen plasma. It contains factors 2, 7, 9, and 10, as well as protein C and S. The dosing of prothrombin complex concentrate is typically calculated based on the patient's weight and adjusted according to their INR level. The recommended dose ranges from 25 to 50 international units per kilogram and should be administered slowly. To ensure sustained reversal, plasma-derived products must be given alongside intravenous vitamin K. However, it is important to consider that prothrombin complex concentrate carries a risk of thrombosis. Nonetheless, 4-factor prothrombin complex concentrate is believed to pose a lower risk than older products. Fresh frozen plasma is generally less effective for rapid INR reversal as it requires larger volumes and is associated with higher risks such as volume overload and transfusion-related acute lung injury. It is typically not recommended for the reversal of oral anticoagulants, but it may serve as an alternative if prothrombin complex concentrate is unavailable. Recombinant activated factor 7A is usually not recommended for the reversal of vitamin K antagonists in cases of intracerebral hemorrhage due to insufficient evidence of its benefit and increased risk of thrombosis. Monitoring the reversal process via INR is critical with target levels below 1.4 or below 1.3 in cases of intracerebral hemorrhage. If the INR remains elevated, it may be necessary to repeat the administration of vitamin K or other factor replacements. When addressing direct factor 10A inhibitors, it is important to note that these medications inhibit factor 10A, and fondaparinux is considered an indirect factor 10A inhibitor. Standard coagulation tests, including prothrombin time, INR, and activated partial thromboplastin time, are typically unreliable for monitoring the effects of direct factor 10A inhibitors. Specific anti-factor 10A assays may be required, but these tests are often unavailable in emergency situations. Clinical decisions in urgent scenarios generally depend more on the timing of the last dose taken rather than on laboratory results. The direct factor 10A inhibitor should be discontinued immediately if bleeding occurs. Andexanet alpha is the FDA-approved antidote for apixaban and rivaroxaban in instances of life-threatening or uncontrolled bleeding. It functions as a decoy by binding to the direct factor 10A inhibitor molecules. Andexanet alpha rapidly reduces anti-factor 10A activity and demonstrated good or excellent hemostatic efficacy in 82% of patients in the Nexus 4 trial, which was a single-arm study. However, it is worth noting that andexanet alpha is associated with thrombotic events, which occurred in 10% of patients within 30 days following treatment in the Nexus 4 trial. Direct head-to-head comparisons between andexanet alpha and 4-factor prothrombin complex concentrate from retrospective studies and meta-analyses regarding hemostatic efficacy, mortality, and thrombotic risk have produced conflicting results. Nonetheless, a large observational study suggested that andexanet alpha might be associated with lower mortality rates. The Annexa-I trial indicated improved hemostatic efficacy with andexanet alpha, though increased thrombotic events were observed compared to standard care, which included 4-factor prothrombin complex concentrate in cases of intracerebral hemorrhage. Current guidelines recommend the use of andexanet alpha for severe bleeding linked to apixaban or rivaroxaban use. In cases where andexanet alpha is not available for the management of direct factor 10A inhibitor-related intracerebral hemorrhage, consideration may be given to 4-factor prothrombin complex concentrate or activated prothrombin complex concentrate, although their mechanism of action remains incompletely understood. The available evidence for their efficacy is less robust than that for andexanet alpha, mainly derived from observational studies and preclinical trials. Dosing for these agents is often based on the patient's weight or set at a fixed amount. Both andexanet alpha and prothrombin complex concentrates carry a risk of thrombosis. Therefore, the cost and availability of these agents can impact which one is selected, as andexanet alpha is significantly more expensive. Administering activated charcoal can aid in preventing absorption if it is given within 2 to 4 hours of oral ingestion. However, it is important to note that direct factor 10A inhibitors are generally not effectively removed by hemodialysis due to their high protein binding, except to a limited extent for edoxaban. Lastly, fresh frozen plasma and recombinant activated factor 7A are generally not recommended for the reversal of direct factor 10A inhibitors. Direct thrombin inhibitors, DTIs, are medications that inhibit thrombin, which is also known as factor 2A. The most common oral DTI is dabigatran. This medication is primarily excreted through the kidneys, and its half-life increases significantly when there is renal impairment. Routine coagulation tests, including prothrombin time, PT, international normalized ratio, INR, and activated partial thromboplastin time, APTT, are not reliable for monitoring the effects of DTIs. However, thrombin time, TT, is highly sensitive to dabigatran levels. Other tests such as diluted thrombin time, DTT, and eccrine clotting time, ECT, also correlate with dabigatran levels, although these tests may not always be available. Management of bleeding complications caused by DTIs is primarily guided by the clinical presentation and the severity of the bleeding. Reversal of anticoagulation is indicated in cases of major bleeding, particularly in cases of intracranial hemorrhage or when urgent procedures are necessary. It is essential to discontinue the DTI immediately if bleeding occurs. If the DTI was taken orally, administering activated charcoal 50 grams, within 2 hours of ingestion may be considered. Idarucizumab, marketed as Praxbind, is the specific antidote for dabigatran. It is a monoclonal antibody fragment that binds to and neutralizes dabigatran. Idarucizumab is FDA approved for situations involving life-threatening or uncontrolled bleeding and for urgent procedures. The REVERSE-AD study demonstrated that idarucizumab caused rapid and complete reversal of the anticoagulant effects of dabigatran in more than 98% of patients when administered in a 5-gram intravenous dose. The use of idarucizumab is considered reasonable and is recommended for patients experiencing spontaneous intracranial hemorrhage associated with dabigatran, classified as level 2A evidence. However, thrombotic events occurred in 4.8% of patients by day 30 in the REVERSE-AD study. In instances where idarucizumab is unavailable, prothrombin complex concentrates or activated prothrombin complex concentrates may be considered, but they do not completely reverse dabigatran coagulopathy, and the evidence supporting their use is less robust, classified as level 2B evidence. Hemodialysis can effectively reduce dabigatran plasma concentrations due to its renal excretion and low protein binding. This may be particularly useful in cases of renal impairment or when idarucizumab is not available, but it carries risks such as dialysis disequilibrium syndrome in patients with intracranial hemorrhage. Fresh frozen plasma and recombinant activated factor 7A are not recommended for managing intracranial hemorrhage related to DTIs. For other direct thrombin inhibitors, such as bivalirudin and argatrobin, discontinuation is essential due to their short half-lives. Prothrombin complex concentrates or activated prothrombin complex concentrates may be considered if needed, but clinical data supporting this is limited. Unfractionated heparin activates antithrombin, leading to the inactivation of thrombin and factor 10A. The effects of unfractionated heparin are monitored using activated partial thromboplastin time. This medication has a relatively short half-life of 1 to 2 hours, and there is a risk of bleeding, including intracranial hemorrhage. If bleeding occurs, the infusion of unfractionated heparin must be discontinued immediately. Protamine sulfate is the specific reversal agent for unfractionated heparin. It is a basic protein that binds to and neutralizes heparin. Protamine is recommended for severe bleeding such as intracranial hemorrhage or when urgent reversal is needed for procedures, particularly in cases involving full-dose infusions. Routine reversal of prophylactic subcutaneous doses of unfractionated heparin is generally not recommended. Protamine dosing for intravenous unfractionated heparin is typically 1 mg per 100 units of heparin given over the preceding 2 to 3 hours, with a maximum single dose of 50 milligrams. It is important to administer protamine slowly through intravenous injection, such as over a period of 15 minutes, to avoid complications like hypotension and anaphylaxis. The effects of protamine typically last about 2 hours, and repeat doses Usually half of the initial dose may be necessary if the activated partial thromboplastin time remains elevated. Excessive amounts of protamine can cause paradoxical coagulopathy. Fresh frozen plasma, prothrombin complex concentrates, and recombinant activated factor 7A are not recommended for the reversal of unfractionated heparin. Protamine is the most specific and effective agent. Alongside reversal measures, supportive care and source control are critical. After a bleeding event, the temporary use of prophylactic parenteral anticoagulants may be a reasonable strategy for venous thromboembolism prophylaxis, provided there is careful monitoring. Low molecular weight heparins primarily inhibit factor 10A and, to a lesser degree, thrombin. Examples of low molecular weight heparins include enoxaparin and dalteparin. These medications are also primarily eliminated through the kidneys, and there is a risk of bleeding, particularly intracranial hemorrhage. If bleeding occurs, particularly in cases of intracranial hemorrhage, it is essential to discontinue the low molecular weight heparin immediately. Urgent reversal is recommended for patients experiencing intracranial hemorrhage associated with therapeutic doses of low molecular weight heparin. Protamine sulfate is the most widely used reversal agent for low molecular weight heparin. However, it offers only partial and variable reversal of its effects. Protamine is more effective at neutralizing the anticoagulant activity against thrombin than that against factor 10A. The dosing of protamine for low molecular weight heparin depends on the specific product, the dose administered, and the amount of time since the last dose. For instance, for enoxaparin, if administered within the past 8 hours, 1 milligram of protamine can counteract 1 milligram of enoxaparin. Protamine is given through a slow intravenous injection. In cases of persistent life-threatening bleeding or renal insufficiency, redosing with typically half of the previous dose may be warranted. Routine reversal of prophylactic doses of low molecular weight heparin is not generally advised. Recombinant activated factor 7A may have some efficacy in certain cases, but carries a high risk of thrombosis and is significantly more expensive. As a result, it is generally reserved for specific cases, such as refractory bleeding or when protamine is contraindicated. Fresh frozen plasma, prothrombin complex concentrates, and activated prothrombin complex concentrates are not recommended for the reversal of low molecular weight heparin. Lastly, the effectiveness of hemodialysis for the acute removal of low molecular weight heparin remains uncertain and is not typically recommended as a standard strategy for reversal.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.